Thank you, Chairman. Thank you, Dr. Ulrich, and also thanks Dr. Reddy for your kind introductions. Today, I want to talk about how does deep endometriosis impact reproductive outcome. The deep endometriosis is a very troublesome hard work for the gynecologist. I'm very pleased to announce our page, ISMIC and Chunjin Haifu have a joint enterprise agreement for promote minimally and non-invasive therapy. And I'm also the chairman of board of trustees. In the 2017, we have a very successful annual congress in Okayama, Japan. And 2018, we have the annual meeting in Surabaya, Indonesia. Ready? Thanks for your hard work. And in 2019, we have a 20th annual congress in Chongqing, China again. It's a very successful meeting. The participants, more than 3,500 people there. And in 2021, APECH 21st Annual Congress in Yokohama, Japan is also a very successful one. They have more than 3,000 participants in this Congress. And then this year, the annual Congress will be in Taipei, Taiwan from the September 30th to the October 2nd. Welcome you to join us. I'm also very pleased to announce our fine journal, GMIT, Gynecology and Minimally Invasive Therapy. They have a very high impact factor. The impact factor is 1.3 in 2021. I expect they will have some more increase in this year. Welcome to submit your fine paper. Today, we want to talking about the deep endometriosis. Actually, the endometriosis in reproductive women is quite a lot. They estimate have a 10% in women in reproductive age. So about 176 million people suffer from the disease worldwide. So the incidence in a symptomatic woman is 2 to 11%. In infertile women, they have 5 to up to 50% have endometriosis. The women hospitalized for pelvic pain, they're up to the 21%. And I want to give you an example. The IVF treatment without a diagnosis of the deep endometriosis or endometriosis not only decrease the optimate clinical practice rate, and it's also have a not without potential serious adverse effect. So we can find the paper from GMIT last year's, a case of an abscess, cystic endometriotic lesions in the vesical uterine pouch after oocyte retrieval. It's quite rare. Most of the TO abscess will happen in the posterior cul-de-sac, but this one is in the anterior cul-de-sac after oocyte retrieval. The paper is from the Dr. Chicago from Japan. It's a 31 years old non-polyps woman visited the clinic due to the worsened dysmenorrhea. So a cystic endometriotic lesion was found in the vesical uterine pouch. Her first oocyte retrieval attempt was performed at IVF center before the planned surgery. And he complained of abdominal pain on day 6 after the retrieval. So Dr. Chicago diagnosed with the peritonitis with an abscess, cystic endometriotic lesion in the vesical uterine pouch. And so they gave them the conservative treatment 2 weeks, but ineffective. So operation was arranged. The cyst of the vesical uterine pouch was drained out. And so they made conclusions. The presence of endometrioma could be a risk factor of developing of an abscess. Also, the small pool of the old blood clot act as a medium for growth of the bacteria that have the transvaginal inoculate at the time of oocyte retrieval. This bacteria can easily grow in the cyst and cause pelvic abscess. So the GMIT published the data about a case of an abscess cystic endometriotic lesions after the oocyte retrieval. So in mild and minimal endometriosis, the mechanisms of a mild and minimal endometriosis with the infertility, because they have a toxic effect on gamete, embryo, and impair of the tuber motilities. And also endometriosis imprint secrete pro-inflammatory cytokine, just like the interleukin-1 beta, interleukin-8, interleukin-6, and also the TNF-alpha, and also the estrogen and progesterone, which attract macrophage and the VEGF and the interleukin-8, thus create an inflammatory status impaired the fertilities. Secondly, they have a normal follicular environment. And because of height in cytokine, and also they have an inflammatory status. So also they have an enhanced ability of the phagocytose, the sperm, by the peritoneal macrophages, and a reduced rate of the fertilizations. So of course they will make infertilities and an impairment of implantation rate, and also the endometrial receptivity. Moreover, for the moderate and the severe disease, they can have an impairment of the oocyte relief because of the adhesions of endometriomas. The oocyte retrieval or oocyte relief sometimes is very difficult. Also, an impairment of the tube transport because of the adhesion formation, sometimes have some phimosis of the tube, and also breakages of the sperm migrations. So they have interfere the oocyte and sperm join together. And what is the best choice for the treatment, medical versus the surgical treatment? Or maybe we need both, but what comes first? Here we will discuss about what will be the best choice and what comes first. First, if the patient have a high risk of the ovarian cancers, in these situations, to have the tissue approved is very important. So that is a patient should have received the surgery. We should note the risk of the ovarian cancer in the patient with the endometrioma. Although they are not evident that endometriosis caused cancer, but some cancer are slightly more common in women with endometriosis, just non-Hodgkin lymphoma and ovarian cancers. And a higher risk of the histologic subgroup of the ovarian cancer, significantly increased risk of the clear cell ovarian cancer. The odds rate is 3.05, and the low-grade serous ovarian cancers odds rate 2.11. The endometrial invasive ovarian cancers odds rate 2.04. They have some endometriosis impaired, some teachers concerned about the endometriosis impaired fertilities. Normally, the monthly fertility rate is about 15 to 20%. But the patient with endometriosis, they will decrease the monthly fertility rates to 2 to 10%. And also, they will impact the outcome. They have a 7% decrease of fertility rate in stage 1, 2 endometriosis. And they have 21% decrease in the stage 3, 4 endometriosis. And also, they have a low oocyte retrieval rate in the stage 3 and 4 endometriosis. And also, they have a consensus for the endometriosis. The surgery for women with symptomatic endometriosis for pain or recurrence, laparoscopic surgery removal of endometriosis is an effective first-line approach for the treating pain related to the endometriosis. And also, the laparoscopic surgery for the endometriosis should always be undertaken in prevalence of the laparotomy when possible. And the hysterectomy is better than just the drainage to minimize the symptom recurrence and the endometrioma recurrence. Should surgery be performed for complete removal of endometriosis before the ART? Before ART, diagnosis and of laparoscopy when performed, the complete removal of the lesions is quite helpful to increase the higher implantation rate and the pregnancy rate and live birth rate in the patient. They have a complete removal of the endometriosis. So in the stage 3, stage 4 endometriosis, if you have a removal of the lesions, they have a much higher of the pregnancy rate, spontaneous pregnancy rate, up to the 57 to 69%. Versus 33% in patients with the moderate endometriosis, and up to 52% to 68% versus 0% in severe endometriosis. So we can find in stage 3 and stage 4, they increase much higher in the pregnancy rate when compared with the not treated group. How about deep endometriosis? Deep endometriosis is one kind of the endometriosis, not the same with the superficial endometriosis or endometriomas. Deep endometriosis have about 1% in women in the reproductive age, about 10% in the patient with endometriosis. According to the anatomy, they will involve vaginous, urocycle ligament, bowel, bladder, and the ureters. So the deep endometriosis also impacted the fertility because they have some adhesions, and also they have some superficial imprint, and also have endometrioma formations, and sometimes they have a getting the adenomyosis. And also they will coexist of other type of endometriosis. And they will produce of the inflammatory cytokine and the chemokine. So it will have interfere with fertility. And it's also, they have a poor follicular genesis. Because of the poor follicular genesis, so they have a fewer oocyte can be retrieved. And also they can have adenomyosis formations, and they have many different forms, includes in the cardiac ligament, urosacral ligament, and also in the cervical vesical ligament. And also reduce the endometrial receptibility and reduce the endometrial receptivities. Also, they can have some hormone receptive functions, and also they have make the immunologic factor have a peritoneal macrophage increase, and the natural killer cells appear in the peritoneal fluid. So in the patient have colorectal deep endometriosis, they estimate they have about 5 to 25% with endometriosis. They have an intestinal involvement, and the colorectal deep endometriosis sometimes present with a subocclusive or occlusive of the bowels. So they have a some bowel syndrome and obstructive bowel syndrome. And the pelvic endometriosis have a significant rate of 2.6 of bowel obstructions. And the intestinal endometriosis was associated with the 14-fold of increased risk of the bowel obstruction, with the rectovaginal endometriosis associated with the 2-fold of increase of risk. So the overall prevalence of the bowel obstruction about 1%, and 27.9% of women with colorectal DIE have a progress as seen by MR over 3 years period. So most of the deep endometriosis, 1/4 of the women suffer from the progressions of the deep endometriosis. How about the endometriosis with urogenital tract? Deep endometriosis may present in renal failure because of the urinary tract obstructions. And so whenever they have the deep endometriosis, you should evaluate the GU tract. And also the majority of the patients with the deep endometriosis have the severe pelvic pain. So the surgical intervention is indicated. But we should remember, evaluate the GI tract and also the GU tract. And also you got the history of the previous surgery is a marker for the severity of the disease, especially for deep endometriosis. And 78% of the patients with the deep endometriosis have a previous surgery of endometriosis, which may allude to a possible elevations of the disease by incomplete surgery. So the complete surgery of the deep endometriosis is a very important work for the gynecologist. So we note the deep endometriosis in the situation we need to perform the surgery. Just like the severe pelvic pain, they have unresponsive to medical treatment, and they have the obstructive uropathy, or they have symptom of the bowel stenosis, or they have a risk of ovarian cancers, or the patient, they have a reproductive desire. So here we show you a patient, they have a braided endometriosis. We can find in the sonography, they have just a mass on braiders, but on the cystoscope, we can find a growth, popular growth of the neoplasm in the cystoscope. So here, we just open the anterior ligament and open the parietal space and identify the ureter. And then after the anatomy have been identified, we attack the lesions on the braiders. So here also have a adenomyosis of the wrong ligament here. So we excite the adenomyosis on the wrong ligament and also identify the ureter. And the uterine basal have been calculated and dissected because they have several applying the artery, so the ascending branch of the uterine artery can be calculated and dissected. So here we can identify the lesions, and the lesions is about 4 centimeters, and the schistotomy was crossed by the 3O micro the two-layer sutures. And before the suture on the bladder, we have put the double Z on the ureters to identify the ureter. And the second layer suture was complete also by the vicro. And then the round ligament have a attachment by the bundle vicrate. So sometimes it's a silent the bladder involvement, but most of them we can see just under the cystoscope and do the biopsy. And then the side in and down, we can direct resections, but on the base, we should dissecting the vesical uterine space and resect the underlying myometrium because of adenomyosis there. So again, we see the patient, they have a deep endometriosis when severe pain, when obstructive uropathy, we have to do the surgery. But in the reproductive design, shall we perform the surgery? Because of the controversy issue, when we look at the deep endometriosis, they may catalog in the minimum of severe endometriosis. So in the HS, when they got the minimum or mild endometriosis, complete resection may improve the art and the spontaneous pregnancy rate. But sometimes in the deep endometriosis, you can identify just before the surgery. So actually, the DE may catalog in the minimum or severe endometriosis. Just like you have a 3 centimeters deep endometriosis because just catalog on the peritoneum. So you just get the scope of 6. So it's a mild endometriosis. But these 2 3 centimeters, they maybe just have a scope 4. So they have a minimum endometriosis. So you perform the resections? Of course, if you can't. Again, sometimes just like we have shown you the 2 cases in the beginning, we do the IVF without diagnosis of the DE, decrease the optimal clinical pregnancy rate, and not without potential serious adverse effect also. So there is a very fine journal, the JAMIC. They have the Gamma, Dr. Gamma have a published data review article and a systemic meta-analysis from the 150 article. And lastly, they have 4 included in the study. They have a DIE surgery, compare the DIE surgery before the IVF and with the complete or incomplete surgery or subgroups with the bowel involvement or not. Finally, they're looking for the complication and the data regarding safety of concern. So the result of the deep endometriosis patient before IVF, according to the systemic review and the meta-analysis, we found the surgery before IVF, if they have a digestive involvement, they have the off rate 2.4. It's favored by using laparoscope to do the surgery before IVF. And DIE without digestive involvement, the order rate is 1.55. So even in the incomplete surgery group, they also showed a higher pregnancy rate. Order rate is 1.63. And the clinical pregnancy rate per patient was 1.84. And the live birth rate per patient was 2.22 times more likely to operate patient than for the non-operated one. He made conclusions is that they have a statistically significant benefit for surgery before IVF, although they should be confirmed with the RCT trial. But addition to the reproductive outcome, the safety data is concerned in the DE surgery. So because of the very difficult surgery for the DE treatment. So maybe that is the last puzzle for the gynecology to learn how to have a DE treatment. Actually, if you know the anatomy, the space, the ligament, or the pelvic floor, then you may easily to perform the deep endometriosis surgery. We can find behind the bladder, in front of the vagina, there is the vesical vaginal space. And they have the ligament, we call it superficialis vesical uterine ligament. And they have a right paravaginal space and the deep vesical uterine ligament just in between the right paravesical space and the right paravaginal space. And also, they have a cardiac ligament just separate the paravesical space and the lateral parabrachial space. And they have a uterosacral ligament, have a separate the right lateral parabrachial space and the right median parabrachial space. So if you want, we have the endometriosis on the uterosacral ligament, we should identify right lateral parabrachial space and the right median parabrachial space. So we can dissect the uterosacral ligament and lesions away. And also they have a greater the endometriosis because of the maybe vesical uterus ligament, they have adenomyosis. So we should identify the vesical vaginal space and the right paravaginal space. Then we can identify and resect the adenomyosis weight. So the space and the ligament here is very important for the deep endometriosis surgery. So here's is from A to Z to identify the deep endometriosis and how to resect the endometriosis. Is a 31 years old woman, and they have a little bit elevated Chyi-Long 125. And so in the sonography, they just have a small endometrioma and the left endometrioma with adenomyosis and DE was suspected. So in the procedures, first, we can identify the tumors and identify the cul-de-sac obliterations and also identify the ureter first before you resect the tumors. Okay, here's the column also that adheres to the left side. So you should identify the median parabrachial space first, then you can identify the uterosacral ligament, then you can resect the adhesion over the uterosacral ligament. So here you just doing the adhesion like this and resect the adhesion over the uterosacral ligament. So here will be the prerectal space. Prerectal space just in between the two parabrachial space, median parabrachial space. So also we should identify the lateral parabrachial space. And here is the ureter, here's, and here is the deep uterine artery. And here also the uterosacral ligament here and the adhesion just over the uterosacral ligament. So we identify the median right side parabrachial space here. And after the two parabrachial space identify, the lesion on the uterosacral ligament could be excited. And also the ureter was identified. Here is the prerectal space, can be identified after you have the two median parabrachial space have been identified. In these situations, the prerectal space could be identified them. So we can use the sharp scissor to dissect these fibrotic lesions. And also the prerectal space have been identified clearly. We can use the rectal probe to help us to identify the space and also the rectums. Also, here is the uterosacral ligament adhesions has been identified and decided. So all the lesions have been identified and resected. So the procedure is very important. The first is to restore pelvic anatomy first before you excite the lesions. And secondly, identify uterosacral ligament, not adhesion. Also, then identify ureter. So you can identify the lateral parabrachial space, also the median parabrachial space. So then after the two parabrachial space have identified, you can create prerectal space. Then you excite the deep endometriosis, and then after surgery, adhesion prevention is necessary for the procedures. So we make a conclusions because half of the women with endometriosis suffer from difficulty in conceive. So expert surgeons have showed the impact of surgery in all stages of endometriosis. It means now, even in a stage 4 endometriosis, rectal involvement of the brain-involved endometriosis, the expert surgeon can do a very good job in the excited lesions. And the laparoscope remains the gold standard whenever deep endometriosis surgery is indicated. ART treatment without diagnosis of the deep endometriosis decrease optimate cleavage rate and is not without potential serious adverse effect. So identifying the endometriosis and the deep endometriosis before ART is very important. And we should perform deep endometriosis treatment before ART if possible. Comparative sector of deep endometriosis is minimize deep endometriosis from evolving and worsen over time, positively impact woman's quality of life. And the approximate radicality of the endometriosis surgery have achieved over the decade in expert referral center. So you had better refer to the expert referral center because of the deep endometriosis. If you're not skillful in doing the deep endometriosis surgery, maybe it's good for you to refer to the endometriosis center. The surgeon have evolved their technique based on their experience. It continue to be the challenges by the complexity of this elusive disease process. Although the surgeons have improved the technique, but the progress of the disease is still. So we should keep in mind the principle of the surgeries. Training will be the last budget for the reproductive surgery, the best training for the best surgeon. I think that is very important for the endometriosis surgery. Lastly, we welcome you to the 2022 ARPAGE Annual Congress. Registrations is open already. So welcome you to submit your paper to the office and welcome you to the TAMIC and ARPAGE conjoint meeting 2022 from the September 30th to October 2nd. Welcome. Thank you for your attention.